All right. Good afternoon, everyone. My name is Erin. My pronouns are they, them, and I'm with Project Echo. Welcome to the Public Health Science Echo, where the public has the opportunity to ask science-based questions for our public health team. For those joining us on Zoom, questions may be entered into the Q&A feature. For those joining us on Facebook, please add your questions in the comment section and they'll be shared with our panelists. As a reminder, we expect all participants to keep questions and comments on topic, to be considerate, and use language that is respectful. So for that, I thank you. If your internet connection does not support audio, you may join us by phone by calling the phone number we've entered in the comment box along with the meeting ID. Closed captioning is available as well. The CC button is on the bottom of your Zoom screen. And thanks to our captioner. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. So our hub team should all be familiar faces by now, and in an effort to maximize our time together here today, we'll go ahead without introductions up top and instead let our hub team members introduce themselves individually during the session when addressing questions. So without further ado, hub team, I'll hand it over to you. Thanks so much.
Great. Thank you guys so much. Appreciate you tuning in to Science Echoes. Please encourage your friends and family, as it is a way for you to hear from our team. We learn from you all, and it helps to be us all more efficient as we're all struggling with the number of cases and the current pandemic. So jumping right in, I'm going to share my slides. Thanks to the public team, for the PIT team, for helping to put these together. And we'll just go through a quick overview where things are at, but want to make sure we leave plenty of time for your questions. And I see them already popping in the Q&A, which is fantastic. So here's where we're at today. So we have 617 new cases to announce today. One note about that, the team is increasing their data entry team because we have been behind on that. So it's important that you look at the report date versus the onset date. So there's some backlog that we've been working through in that space. So take a look at those different tabs. We have had a 32% increase. You'll also notice this is a kind of a change in the way that we're presenting this data to try to make it more streamlined and help to answer some of the commonly asked questions that the media and public ask on a regular basis so that information is transparent and across the state. Just over 78,000 total cases, and unfortunately have passed the 400 mark with total resident deaths to date. And you'll see these alert levels again change to census and borough area, and they now match or are more closely aligned kind of with the CDC's 4 different alert levels that you can see across the state. So happy to talk more about that, but we went through that before. Here is just our overall graph, and we're looking at a period of time. We had a nice bit in the summer there, but the Delta variant is different, and Delta spreads quickly. We're clearly seeing an increase since July 1st. We have seen, over a 700, almost 800 nationwide % increase of cases over the last 7 days. Again, this is the national trend on the big one, and then you can see the Alaska trend on the bottom, or that lower left corner, and you can say kind of a similar sort of trend overall. Delta continues to be widespread. Reports out nationally, we're about 97% of all sequence cases nationwide are Delta variant cases. Again, that's that deep orange box on there. And because of Delta variant, we are seeing many things, but including the Delta variant that moves more easily from person to person. We continue to see a lot of cases across the state. Again, we shared this slide before, but this just really talks about the fact that this disease really transmits more easily from person to person than the original virus that we saw, much more easily than something like influenza, and less so than mumps and measles, and why we're asking people to take measures to protect themselves as well as their community and their family. Here's our % positivity rate. Again, we'd like to keep that less than 5%. It continues to climb. We're at 7.5% positivity right now, and you can see we're starting to reach kind of the peaks that we had last November. We're not there yet, but this is not going in the direction that we would like it to go, and encourage people to get tested at the beginning of any symptoms or if you've been exposed. Again, there's travel guidance for unvaccinated individuals. Some places are using regular surveillance testing. Happy to answer questions about that, but testing remains an important tool to identify cases early. The other thing that testing can do is to help to identify if you're COVID positive, to see if you would meet criteria for monoclonal antibodies. So there is treatment out there for COVID-19 that can help prevent hospitalization, but it works best early before you need hospitalization. And so it's important that people get tested to know if that treatment was available. We are behind on our contact tracing as well as our, again, the data entry system. And so friends don't let friends spread COVID. So if you find out that you're COVID-19 positive, please isolate for 10 days and let any of your close contacts know. And so we've done the same things that we've been doing for the last 18 months. This takes every one of us being able to get tested quickly and letting our close contacts know if they happen to be positive. We did update our vaccine dashboard to kind of provide some more trends and information. We're almost at 60% of residents 12 and above have received at least one dose. You can see in the last 2 weeks, we have had over 12,000 doses of COVID-19 vaccine administered. So we continue to see people choose to get vaccinated, and we'll continue to move at the speed of trust. This has been a 5.9% increase when we compare to the 2 weeks before then. And you can kind of see this February through August trend. So a little uptake there, but we know that we have a lot more Alaskans who are currently not protected. And we talked about last week, those who have had COVID-19 before are more protected if they get vaccinated after a previous infection. They are about 2.5 times less likely to get COVID again if they've been vaccinated. So even if you had COVID-19 before, please consider getting vaccinated. There was information last week about an additional dose, a third dose of mRNA vaccine for those who are immunocompromised. We are getting some feedback that not all the vaccine sites are smoothly rolling this out, and we are continuing to try to message to them that this is CDC's recommendation, and anyone who's immunocompromised, like a solid organ transplant patient, should consider getting a third dose. So we'll continue to work to make sure that every vaccine facility in the state knows this and is allowing you to get your third shot. But if you're immunocompromised, consider getting a third dose of an mRNA vaccine. We also heard an announcement today about a pending booster dose. So this is for someone who has been 8 months or greater since their first set of shots. It's not quite there yet, but September 20th, we're kind of building for that timeframe. So this was announced today. There's a bunch of studies that help to support this decision that came out from the federal government today, a series of MMWRs that just got released today. They continue to look to be very protective, particularly for the healthy, but those who otherwise have underlying health conditions continue to see kind of waning immunity and this need over time for a potential third dose. So we've got a couple different MMWRs that are recently out and just wanted to highlight that. We also know that kids can be impacted by COVID-19, not only from missing school, but also get sick and hospitalized. This is the national conversation that is happening regularly. It's just the number of kids that we're seeing increasing with hospitalization. And vaccine continues to be our best way to protect them from getting COVID-19, from getting long COVID, as well as the off chance that they get really sick and require hospitalization. Again, they're much more protected than adults, but they're even more protected when you're sending them off to school and other places if they are vaccinated. We're still at the 12 and above, and we're still anxiously anticipating a younger age group, but we need that data first. Here is a breakdown by census and borough region for the 12 to 18-year-old age group on vaccine status. So kudos to many of our regions where they've already got 75% of their 12 to 18-year-olds vaccinated. You can see we see a large variety of vaccine rates across the state, and we continue to see nationally that when a community has low vaccine rates, they have more cases, they have more hospitalizations, and they have more deaths. So vaccine continues to be our best tool against this pandemic, and encourage people to talk to your provider, ask us questions, and consider getting vaccinated. Right now, as COVID is spreading and the Delta variant is here, we need to take a layered mitigation effort. It's kind of like going outside with multiple layers in the winter. In the summer, you might just go on with a light jacket and call it good. And that was this summer. You're vaccinated, you're pretty good. But right now it's pouring rain in Alaska. We got a lot of COVID cases. It's pouring rain outside my window as well. But you need to layer up. And so that may mean not only vaccination, but when you're in indoor spaces, also masking, keeping your circle small, realizing that when you have a lot of COVID in your community spreading, it increases your risk of being a vaccine breakthrough case, picking it up, spreading it to other people. Again, vaccines still work amazingly well, but they're not 100%. No vaccine is. And so we need to potentially layer where we got a lot of cases going, which is right now. Back to school, we know there's a lot of benefits of kids going back to school. Matsu School District went back today. Anchorage went back yesterday. I know lots of kids are kind of seeing teachers, some of them for the first time in a year and a half. Some were in person last year. We had a lot of success last year when we were able to have COVID mitigation strategies. So when masking was a tool and people were distancing and cohorting, we did not see much spread in schools, and it was fantastic. What we saw was spread outside of schools when people took off their masks and sleepovers and parties and things like that. But we now have the Delta variant, which moves more easily. And so we really need to take these mitigation strategies seriously as our kids are entering back into school so that they can stay in school, they can stay healthy, and our families can stay healthy as well. We know our kids live in communities. So as we move back, let's just make sure we give each other space and grace. This has been hard for all of us. We all wish COVID was over. We all wish this wasn't here, but it's here, and we got to do the best we can. Our kids are listening, they're watching. And so I think, really just trying to be positive, prioritizing their mental and physical health, making sure if they're eligible to get vaccinated, they are, and you as an adult are vaccinated to help protect them. Test often. Any symptoms. You might have just thought that it was allergies or a cold. It can be impossible to tell this virus from other ones. So test for any symptoms and use layered prevention, such as sending your kiddo to school masked, not having them do, sharing water bottles with their friends, thinking about the other spaces where kids get together. We have a lot of information on our website, including mental health tools and back to school PSAs and toolkits. Please consider taking a look at those. We have a speakers bureau that will come to any group meeting to kind of answer your questions specifically. Again, I touched on monoclonal antibodies. This continues to be an effective tool to minimize hospitalizations, particularly as our hospitals are very stretched right now, and we want to prevent you from being hospitalized. So if you test positive for COVID-19, talk to your healthcare provider. There's information from HHS that really goes through who's eligible. And this also includes high-risk close contact. So consider monoclonal antibody treatment. Our hospitals continue to be quite strained and honestly overwhelmed at this time. They are having to change their care for everything from strokes to heart attacks to other care. And so this is the time to drive safely, wear your seatbelt, wear your life jacket, but also slow COVID down. Here you can see our hospitalizations and where they really kind of hit a point of a lot of surge back in last November. And you can see here where we are now, we're not quite at that same point, but it continues to pick up in our hospitals. So currently 13.7% of our hospitalizations are COVID related. Again, that's not all, but this is a significant number of patients. 127 Alaskans are currently in a hospital bed right now because of COVID-19. And that's a younger age group than we saw last November, primarily because our younger age groups are not hospitalized. Masking continues to be an important tool. There are standards for kind of masking. If you're questioning or wondering what mask to use, you can always look up this ASTM F3502 standard, and that's kind of regarding kind of cloth face coverings. I wish they would have chosen a simpler way to say that, but there it is for you. But the biggest thing is making sure that it fits really well, that it's multi-layered, it's comfortable, it's breathable, and there are many out there that are reusable. Making sure you take a look at the instructions, including washing and the number of washing and cycles that are available. But there has been kind of the standard now since April regarding cloth face coverings, and encourage people to take a look at them because they're all the same. Alaskans working together have saved lives. So this was a Medicaid report looking at similar states. We all got similar funding for vaccines. We all got similar funding for testing. And if we looked at similar states, when this report was run, again, this is a little bit old now, this is back in July, we would have expected significantly more deaths and hospitalizations overall. So here, when you look at Alaska, we had 370 deaths at the time of this report, 1,600 hospitalizations. And we would have expected more like 1,263 deaths and 4,000 hospitalizations. So Alaskans working together have saved almost 1,000 lives and almost 3,000 hospitalizations at the time of this report. This also translates to money. This is almost $60 million of Medicaid and $10 million of GF. Prevention is cheaper, prevention works, and we need Alaskans to choose this to be able to stay healthy and well and safe moving forward. Our website continues to be hacked, and I know it's really frustrating, and continue to try to get it up. We have this like mini one up there that we're trying to make sure the most useful tools are up there. So again, I encourage people to take a look at it, and we are hoping for a non-hack day of our website sooner rather than later. So with that, thank you all for your time and effort. No epi curve goes up forever. No pandemic lasts forever. This too will get better, but how much we're impacted is going to depend on what we as Alaskans do together. Thanks.
All right. Well, Hub Team, do you want to jump right into questions? Excellent. Sounds great. So our first one, which I know is quite common. So does needing a booster shot mean that the vaccine isn't working? And do many other vaccines require multiple doses and boosters?
Yeah, Lisa, we want to take that one?
Sure. So great question. And the CDC has released a lot of new information today. And it's kind of helped shape this discussion around booster doses that we're looking towards in September. So one of the large studies that did get released was a Mayo study, and they looked at about 50,000 patients, and that was from January to July. So some of those were pre-Delta, some were post-Delta. But basically what they found is, the vaccine efficiency in the beginning was around 90% for both of our mRNA vaccines. And we saw a significant decrease. So going down into the 40s to 70% after Delta kind of started circulating. They've actually released a few other studies kind of talking about decrease in vaccine efficacy with the Delta variant and kind of breakthrough infections. There's a few questions in the chat box regarding this study specifically, kind of saying, is Moderna better than Pfizer? Because they did see a less of a decrease in efficacy with Moderna over Pfizer. And really, we don't have enough information to say that at this time. Both of these vaccines are pretty equivalent. And so this was a preprint and it hasn't been peer reviewed yet. I think it's good global data to look at, that there is a decrease in efficacy, but not enough of data at this point to say, yes, one of the mRNA vaccines is better than the other. I don't know, Joe, if you have any other thoughts on that.
Yes, I do. I thank you, Lisa, for starting this conversation off. It's something that is rapidly evolving, and I think the new studies that came out from CDC today are very helpful. So I'm going to go ahead and share my screen, and we can take a look at a couple of them. This first study, Lisa, can you see this? This table? Okay. So this first study came out of MMWR today. It's entitled New COVID-19 Cases and Hospitalizations Among Adults by Vaccination Status in New York, May 3rd through July 25th. So they go into the Delta era, where Delta really has become the predominant strain here. Here's what they found. For new cases, going back to May 3rd, May 10th, the vaccine effectiveness, here's the estimated vaccine effectiveness, was in the low 90s, 91, 92, 91, 92, and that stayed pretty consistent through the end of May. And then into June, we started to see a drop into the 80s in July. And now what we've seen most recently through July 19th is it's dropped into the high 70s. And this is effectiveness against new cases of COVID-19. Now, take a look at hospitalizations. This is the optimistic aspect. You start up here in the 95% range, May 3rd, May 10th, you're kind of staying high in that mid 90s range. And look at this, it stayed consistent all the way through. So this is a really reassuring study that although the vaccine effectiveness appears to be dropping for new cases, it's still highly effective, much, much more effective than, for example, the flu vaccine. But what we're not seeing is a drop in the vaccine effectiveness against new hospitalizations. So that's fantastic. Here's another study. Now, this one was also published today. It's entitled Effectiveness of Pfizer, BioNTech, and Moderna Vaccines in Preventing SARS-CoV-2 Infection Among Nursing Home Residents Before and During Widespread Circulation of the Delta variant. So this one goes through August 1st, March 1st through August 1st, so into the Delta era. Here's what we see. So here is any mRNA vaccine. Here's the Pfizer, here's the Moderna, and here are unvaccinated people. They're considered to be the referent group. And we look at the vaccine effectiveness. Let's take a look at the Pfizer first. Vaccine effectiveness in their adjusted model. What we found is in the pre-Delta period, which is this line here, the vaccine effectiveness for nursing home residents, and this is preventing SARS-CoV-2 infection, just infection. It's not even symptomatic disease. So remember, you've got infection, you're infected with the virus, and many of those people can be asymptomatic. And then the next level is you're infected and you've got actual symptoms, a cough, fatigue, runny nose, loss of taste or smell, shortness of breath. And then the next level is hospitalization and then ICU stay and death. So this is just looking at vaccine effectiveness against infection. And here's what we see. It has dropped from 74% down to 52%. And if you look at Moderna, it dropped from 74%, almost 75% down to 51%, basically. So they're basically equivalent. So that is what we're seeing with respect to this drop in vaccine effectiveness against infection. There was a third study that was also published today that basically showed similarly robust vaccine effectiveness against hospitalization. So that's kind of, hopefully gives you all the general sense of where things are going with respect to vaccine effectiveness and why CDC has come out with this new guidance recommending a booster dose because they think that not only is Delta virus variant playing a strong role in this, but it might also be that waning immunity is playing a role. And in fact, there's good evidence to support that.
And just to summarize for everyone out there, this is the same vaccine, so it hasn't changed with the Delta, but we'll continue to watch that closely. If you're immunocompromised or equivalent, you can get a third dose now at any local place. We continue to try to make sure that they know that and let us know if you're getting pushback because we continue to get the messaging out. And then if you are 8 months or greater since your 2 shots, your vaccine, around September 20th, then it will be time to consider getting a booster shot at that time, given that data that's out there. So those are the takeaway action items for you all. Kelsey, anything else you would add from a vaccine standpoint, since there are a lot of questions in the chat box on this topic?
You know, I think it's that wording matters now, you know, and really trying to think about what that primary series looks like. So for individuals who are not immunocompromised, that primary series is still 2 doses. If you are in that immunocompromised group, and we can make sure that you know, is put into the chat, you know, there's some very specific definitions of that. Your primary series has changed to 3 doses. And so that is the group that we're focused on right now to do that additional dose. Boosters, as Dr. Zink mentioned, that information will be coming and you all will know when that is live. But really now we are just focusing on that 3rd dose, which is an additional dose for a primary series for folks who are immunocompromised.
And there's another question about, you know, why are we talking a lot about the mRNA versus the J&J? You know, Joe showed some of the data. We don't have quite as much data. Kelsey, what would you tell someone if they are immunocompromised and received a J&J dose?
That we're still waiting. You know, we just don't have that recommendation right now. We hopefully will get, I think I heard recently that in the next couple weeks, we're expecting to see more information on that. But unfortunately, right now, we are just talking to those individuals who received either a Pfizer or a Moderna vaccine and not a Janssen or J&J.
Awesome. Thank you, guys.
Excellent. So another question related to the 3rd dose. So will the 3rd dose of the COVID vaccine be available to the ALHs the same way it was last time, wherein the pharmacy went out to give shots?
And Matt?
Sure, I'm happy to answer that question. So there are conversations started around this with the CDC, and we are looking for a 2.0 rollout. What that will look like, we don't know yet. So we're still waiting on guidance from the CDC, but as we receive more information, we'll let everyone know.
All right, thanks, Matt. Dr. Cutchins, we have quite a few questions here related to ivermectin. What is Alaska's and public health stance presently on ivermectin, and could it be useful in the current uptick?
The first thing I'll mention is the Alaska State Department of Health or the state is not a governing board for medication use. Ivermectin is an FDA-approved drug. It's mainly used to treat intestinal parasites, not viral infections. You know, old drugs like ivermectin gained a lot of attention early in the pandemic because they were looked at on computer modeling and effective against the virus in a simulation, you know, drug versus virus directly. Now, I will say in terms of medical literature, what we've learned from ivermectin is, unfortunately, it doesn't work in the human. You know, when we do these modeling, it's sort of drug versus viruses, but when we look at drugs in a person, you know, it has to get to the site, it has to work in the body. You know, there's a lot of misinformation out there about ivermectin. You know, I wish ivermectin worked, but unfortunately the data doesn't support it. There's a lot of misinformation about it being widely used in India, but I'll add that India's COVID guidelines don't recommend using ivermectin. From what I can tell, it wasn't widely used there. Also, none of our current guidelines, either the Infectious Disease Society of America or the NIH guidelines, recommend using ivermectin. All that said, though, there's nothing to prevent an individual provider for prescribing ivermectin for their patient. It's an FDA-approved drug, and that's completely fine, and no one's going to stop them. But current data does not recommend or look like ivermectin is going to be an effective treatment. So far as to the Merck, the drug company who produces ivermectin here in the U.S., have said they're not going to study it because none of the data supports its use.
The other thing that I would add on that topic is, we have kind of just different conditions around the world. There's a really heartbreaking story about Indonesia and all the kids that have died, and like the number of thalassemia cases and TB, and we all live with kind of different diseases and different situations. There are many countries in this world who have higher parasitic loads, and they're also using different amounts of immunosuppressants, such as steroids, that can cause parasitic diseases to be larger. And so some of the data that you may see from some countries with certain treatments like ivermectin may play out really differently here in the US, where we don't have large parasitic burden. So I think it's important that we learn from the world, but I think it's also important to look at local as well as our national circumstances and the data that we're seeing here. So just a couple of things for consideration.
All right, and some additional questions here on monoclonal antibody treatment. Dr. Cutchins, perhaps you could take these as well. Our first commenter shares or asks, is monoclonal antibody treatment indicated for those who test positive but are asymptomatic?
Yeah, so monoclonal antibodies are the class of drug that we do have really good data on for outpatient infections of COVID. So these are a class of drugs that are either given via subcutaneous injection or IV infusion. They're best if given early. So the first moment that you test positive, and as soon as you have, or even the mildest symptoms and test positive, or with one of the preparations, the Regeneron is now indicated for post-exposure. So that means if you are at high risk of progression and have been exposed to someone with COVID, you can get this as well preventatively. We've already talked about that criteria a lot. The sooner the better. So yes, if you test positive and you're deemed and you want to go to get infused and the provider seems it appropriate, you can get that drug right away.
And Dr.
I'll also add that, on the questions about access, so we are working on expanding our website to get more availability. Many providers around the state have monoclonal antibodies. They're a drug class that's available through the federal government. We have updated our vaccine hotline with sites that are available to the public. Also really recommend reaching out to your primary care provider if you have one, as they may have them available through their clinic for their patients. And I'll put that number in chat and recommend anyone calling that if you're having a hard time getting access.
And I'll also put in chat, there's a national website for searching that has some, but not all. We're working with them to have more of them listed. And HHS has a good website that you can go through and look at kind of, do you qualify, do you not, like who benefits and who doesn't. Again, this is a good tool for preventing hospital stay, but I see so many patients who show up to the ER sick enough to require hospitalization, and now they're interested in vaccine or monoclonal antibodies. Again, vaccine is prevention and works earlier. Monoclonal antibodies is for before someone's sick enough to need hospitalization. It doesn't have the benefit when people need hospitalization. So that's why it's important to get tested early and seek these treatments early.
Thank you so much for that clarification. Is there an age limit for monoclonal infusion?
12 and above.
Okay, excellent. All right. Any predictions at all when vaccines may be available for the 5 to 11-year-old age range?
So Pfizer, the trials have met enrollment, which means they don't need to enroll any more people. That's good news because now we're on kind of a real timeline. Before trials meet enrollment, we're always sort of this like rolling 4 months out. I'm still thinking like November-ish, could be a little bit sooner, could be a little bit later on Pfizer for our 5 to 11-year-olds. And then for 6 months and up, Pfizer and Moderna are both still enrolling. It's looking more like, early 2022.
All right, switching tacks a little bit. If one receives the third COVID-19 vaccine, how long should a person wait before receiving the flu vaccine?
Matt?
The flu vaccine can be co-administered with the COVID-19 vaccine. If there are any changes to that, there'll be an MMWR with flu recommendations coming out pretty soon.
All right, thanks so much, Hub Team. Question about symptoms. Do COVID symptoms differ between variants and or whether an individual is vaccinated?
Great question. Maybe we can all chime in here. Symptoms are impressively varied on what people will look like. In general, people who are vaccinated tend to have less symptoms, but no significant change between what they may have. So they may have a sore throat or runny nose, think it's allergies, shortness of breath, loss of taste and sense of smell. And so see a large variety. I don't know, Joe, Louisa, Liz, other things you'd add on that one?
No real data on this. The questions come up on national calls as well. No indication that there are varied symptoms by variant. One question has come up is if you have an infection with the Delta variant or another variant, is that more likely to give you more pronounced symptoms or more severe disease? And we don't know the answer to that question yet.
All right, so for people who test positive via home antigen tests, how do they get in contact with public health? Is there a number that they can call to self-report their positive result?
Louisa, what would you tell people?
I think we put something in the testing guidance about that we would recommend they get a confirmatory test. I guess they can call the main epidemiology number, the 269-8000, or they can connect with their local public health center. I think, the recommendation is going to be to have a confirmatory test. And so that might be the first step to take, is to go ahead and, depending on what community you're in, go ahead and seek that testing to confirm that that is indeed what the result is. Especially if you're a high risk person, I think probably a call to your provider would be a good idea to just say, hey, I've done this home test kit, this is my result, and sort of get an individualized recommendation based on that. I think other folks?
Yeah, folks can also reach contact tracers by either calling 211, they can connect you the contact tracing program, or there's a number 907-531-3329 to talk with a contact tracer, but definitely encourage you to get the confirmatory test and let your provider know.
The only other thing that I would add is thank you for getting tested. Make sure that you isolate from others and let your close contacts know. So our contact tracing teams are trying to keep up, but they are behind. So the more you can let your contacts know immediately, that's going to be the most important thing. Thanks.
Dr. Zink or others, would you mind explaining why it's important to get tested when symptomatic? And we have a question here from somebody who was wondering why not schedule testing independent of symptoms?
Yeah, I'm happy to start and the others can chime in. So a couple different things, that viral load starts to peak right as people become symptomatic, although some people are asymptomatic. So it's a great time to test, not waiting 2 to 3 days to think if maybe my allergies will just go away or the sore throat will go away. So test early because that will be able to help to minimize your spread to others, as well as letting your close contacts know. So if they're asymptomatic and early in the disease, they can stay away from others. They might not go visit grandma at that time. They might go ahead and stay home and get tested. So it helps to inform us all. You may benefit from monoclonal antibodies. So that's another reason to get testing. There are people who are doing kind of regular surveillance testing, such as the workers in our long-term care facilities. There's testing recommendations for travel or after exposure. There is testing guidance, for things like schools and looking at surveillance testing to test early for documentation. Our biggest bang for the buck is going to be in that early symptomatic, but there is a role in other places. Louisa, what else would you add to that?
No, I mean, I think especially now that there's a lot more home testing kits, I think people are sort of choosing to have those on hand for different circumstances. As Dr. Zink mentioned, there's sort of industries and work settings where there is that surveillance testing and sort of some more tailored guidance for frequency of testing and how to interpret that. I think, yeah, anything else that folks want to add? I don't know, from in the healthcare setting, do you want to talk about that, or those are sort of specialized situations?
Yeah, I can mention, I'll speak for myself. Over the weekend, I had a little bit of a scratchy throat and a little sniffy nose. I went and got tested. I went to the airport. It was amazingly efficient and fast. I did a rapid test, which I knew the result in about an hour. and also did they do also a molecular test, which I had the result of that within about 36 hours. And I tested negative, but in the meantime, I think it's important, if you're symptomatic, wear your mask and separate yourself from your family members, because if it turns out it is positive, you could be shedding the virus and affecting others. So if you're symptomatic, almost behave as if you are positive until you know you're negative. So I think that's what I recommend to my patients as well.
And I will just add, we'll continue to support airport testing. So those are available and there, and continue to work with schools. They did get money to support testing to make it as easily and accessible there. Different school districts have chosen to use that in really different ways. And then communities continue to work on making sure testing is available, free, and easy to access. It's not always perfect. The home tests that you can get over the counter are great. They're the same as the ones that we use in other places. They're the Buy Next Now cards, and those can be purchased at Fred Meyer's and Walgreens and Walmart as well. So as Louisa mentioned, have a plan to get tested so that if you wake up like Dr. Demain with a sketchy throat, you got a plan on how you're going to get tested so that you can get those results back as quickly as possible.
All right, thanks, Hub Team. Why is there such a testing disparity among Alaskan communities? In Haines, for example, which is currently experiencing its biggest outbreak yet, testing is by appointment only. Only symptomatic people can get rapid tests. Tests for asymptomatic people are sent to Sitka, and results take several days. In other parts of Alaska, like Juneau and Homer, free walk-in testing, no matter symptom status, is widely available. What explains that disparity?
Yes, it's a fantastic question. I'll start with an answer, but I don't know, Sarah, you might have some insight, particularly in the Southeast region. You know, communities have been provided with federal dollars to be able to set up testing, and it's been interesting to see different communities choose to use this in different ways. We continue to message out the testing that you can choose yourself, like the at-home testing, as well as the Abbott Now testing or the Buy Next Now cards that you can be able to get in your community as well. So we see just different communities interacting in different ways, and we continue to reach out to them. Sarah, what would you say, and Coleman?
Yeah, I would agree with what you mentioned. Each community has kind of chosen a different way to handle how they do testing, the resources available. The state of Alaska remains available to provide support for pop-up testing if the community would like to have that. So that continues to be available if that request has been made. In terms of being sent to Sitka, that's search covers Haines and Sitka, so that's probably an internal processing decision, and so it's not something I could speak to, but if the community desires additional help with testing, certainly we'd be available to support that, as we have in many other communities.
Yeah, I'll add, this has been it's been a flow the entire pandemic. Early on in the pandemic, way better access to testing in remote communities than our urban areas. It used to be very difficult to get testing in our larger cities. So it's kind of come and gone. Some communities have had better access, had worse. The consistent is that, here at the state, we provide support to any community. We do have some free testing resources available. We have swabs and media that they can send to lab. We have rapid options. It's also important to remember some of the biggest limitations of rapid testing is they can't test a lot of people. It's good when you have one person standing in front of you, but when you have a whole lot of people that have to be tested, a lot of those tests have to go to lab. So happy to work with any community. Just reach out and ask.
All right, a question about the daily summary report. This participant asks, the daily summary report is for the previous 24-hour window. Can you change the report to show actual deaths and hospitalizations within that 24-hour window? It's confusing to say 4 deaths on August 17th, but the table shows those 4 deaths spread out over almost a month.
Yeah, I'm happy to take a dive at that, but Elizabeth and Louisa, also curious in your guys' perspective, one of the challenges with hospitalizations and deaths is the reporting can be really lagged, and we might receive, 4 deaths at once that were over a month's time on very different dates. And so that's why we really ask you to look back on those previous ones. And it's part of the reason that hospitalizations and deaths, we tend to report cumulatively as well. In those case updates, we also don't want to hide information. So as soon as we have it, we share it in those case updates. Again, not trying to drive any fear, but particularly in this state where we don't have tons of people, we get a lot of variability in our hospitalizations and deaths, which is very different than a state like Florida or Texas, where they just have so many more people. Louisa, Elizabeth?
Yeah, I mean, I guess what I would say is that report, that summary report that comes out for what was kind of recorded that day really, really is just that, what was recorded that day. When the numbers are super small, we know, and the turnaround times at labs are like a day, it's pretty real time what's going on. But when there's a lot of activity, and I mean, just think about somebody who gets sick with COVID like a week ago, they sort of manage themselves at home, and then they go downhill, and then they get hospitalized, and they get hospitalized for 2 weeks, and then they die like 3 weeks later. Like, none of that lends itself to sort of telling you what's going on right now. So I think it's important to just think about that date of report as what we've recorded that day and not necessarily what has happened that day. That's why there are all these other options for looking at timeframes of like, what's the onset date and where did that hospitalization occur and when did that death occur? And it's also why there's information that comes out later in details about the length of stay of the hospitalization, the time from somebody being positive to when they were hospitalized and when they died, and the duration of that infection. I mean, it's really more complicated than just what's happening on that day. So I guess that's what I would say. I don't know that there's a way to, yeah, I guess that's what I would say, is that it's more complicated.
And I don't really have anything to add except just to, you know, in case people aren't familiar with the daily summary that gets sent out, you can subscribe to it. It's really just the data that's on the dashboard. And we just compile it in a way, you know, so that it's easy for everybody to see everything at once for people who prefer it in that format. The only thing that's not on the dashboard that gets put into that daily summary email is just the age and sex of the people that have died, just for a little bit more detail there. But I think that even is captured on the dashboard somewhere as well, but it's just clarifying what the daily summary is. Thank you.
All right. So this one, I know is pretty common. Why should we wear masks if the virus can pass through them? And also, why get vaccinated if you can still get and spread COVID? Hub team.
Anna, you want to take the mask?
Yeah, sure. So couple things about that. Masks are very good at preventing transmission of the virus. So sometimes people get caught up in the size of holes and the size of the virus. And it's kind of the thing is that viruses are very tiny. It's totally true. Individual particles of virus are extremely small and they will pass through many, many, many kinds of filters. But the virus isn't just floating around all by itself as a little tiny single individual virus particle. It's stuck inside a giant bubble of spit or snot. Like a pit inside a cherry, like a small toy floating in a water balloon, whatever thing you'd like to think about. So while the virus is very small, that droplet that's containing it is much, much, much larger. And so those particle sizes are very effectively stopped by fabric. Just like if you hang up a sheet and you try to mist water at it, you will find that your hand on the other side is pretty dry because the fabric does catch all of those droplets. There are lots of fun demonstrations on exactly how well this works you can find online, ranging from flamethrowers to spraying water, so you can go check that out and perhaps possibly with some safety precautions duplicate some of those with your children. Did you want to speak about masks or vaccines, or did you want me to do that?
You know, I can just say a few words about why get vaccinated. And I really wanted to show you all this table, so this is a good opportunity to do it. This is something that I didn't share with you last week because I hadn't read it yet, but this is a very helpful table and I think can be very convincing to folks who are still on the fence with respect to vaccination. This comes from an MMWR entitled Use of COVID-19 Vaccines After Reports of Adverse Events Among Adult Recipients of the J&J, as well as the mRNA vaccines. And what it goes through is the benefits and the harms associated with vaccination per 1 million doses administered. And it has the Janssen vaccine as well as the mRNA vaccines, and it breaks it down by sex, females and males, as well as age groups. So if you just take a random, let's just say we take a look at the Janssen vaccine and women aged 50 to 64, What are the benefits of that vaccine per million doses? You're going to prevent 12,000 cases. You're going to prevent 1,600 hospitalizations. You're going to prevent 350 ICU admissions. You're going to prevent 120 deaths. And what are the harms? You may experience 7 to 8 cases of Guillain-Barré syndrome and 3 to 4 cases of thrombosis with thrombocytopenia syndrome per million doses administered. Now let's take a look at the mRNA vaccines, and let's just take a different age group. Let's take males greater than or equal to 65. You're going to prevent 52,000 cases of COVID. You're going to prevent 12,500 hospitalizations. You're going to prevent 3,500 ICU admissions, and you're going to prevent 2,400 deaths. And you're going to expect to see 1 case of myocarditis. So I think hopefully that answers the question of why get vaccinated.
And then I would just mention along that, since we see the question in the chat box, myocarditis is usually self-limiting, does not require treatment, does not require hospitalization. And so we do see it. We also see it from other viruses, including COVID and influenza. So it's often caused by viruses itself. So I just want to put that in perspective. I also get asked, how come other VAERS data is not listed on there? And again, because we may see things that happen at the same time, but that doesn't mean that they were caused. They weren't happening at a higher threshold than we would see with other things. It's really this TTS, the Guillain-Barré, and the myocarditis that we're seeing at slightly higher rates than we would at the baseline with people who have not had COVID and not been vaccinated, and why those are kind of the things that are compared to. Lisa, anything else you'd add to that one? Okay.
I think that's exactly right. And I think with all of this new data, and Joe pulled up that study earlier, we definitely have seen a decrease in efficacy with the vaccines, but continue to have great coverage for severe disease, hospitalization, and death. So the things that really matter. So we really want to continue to encourage vaccination.
All right, thanks so much, HEP team. Dr. Cutchins, could you recommend a couple of tests for folks who are anticipating travel?
So that's a very complicated question. And if you are going to travel, you really need to be aware of where you're going, what the requirement is. Some places like Hawaii, it's not a question of the test, it's a question of the organization offering the test. So you have to use one of their preferred providers. They do have an at-home kit, Vault Health, that meets their criteria. You know, some countries require specifically PCRs. Some countries accept all different. So really encourage you, if you are going to be traveling to somewhere that requires a test, make sure you really read the details on what type of test they accept, or if there's a certain place you have to get tested.
And building off of that, for folks who are fully vaxxed and flying but have no symptoms after a few days, will 7 days of no additional exposure be okay before visiting non-vaxxed friends and family?
Great question. I would, one, make sure that you're vaccinated, and 2, consider testing after that travel as well. So if you're going to be away from them for 7 days, that will help, but then get tested before you see them. That will provide an additional layer of protection for your unvaccinated friends and family.
All right, thanks so much, team. What are you seeing in terms of burnout among healthcare staff? What are they saying exactly?
Yeah, so Lisa, I think we can kind of tag team this one overall. It's heartbreaking right now working in the hospitals. It's the most depressing place I have worked in my career. You see people who have dealt with HIV and bombs and have gotten black eyes and have dealt with earthquakes and have been there. And this is exhausting. And it's been happening for months upon months. And now we're seeing so many sick people who it's completely preventable, or at least majority are preventable. I mean, it is unvaccinated person after unvaccinated person who's struggling to breathe, saying, I didn't think this would be this bad. What's happening then is it's backing up everything else. So the kiddo who needs a laceration repair, the guy who's having a heart attack, the car accident, the 14-year-old femur accident from a dirt bike, there's no beds. There's like nowhere else to get them. And so it's really challenging. So you're calling around everywhere in the state, you're calling outside of the state. This is happening nationwide. So it's becoming harder and harder to get the staff that we need to be able to see there. There was a great little meme that showed a hospital burning and someone walking past oblivious on their cell phone. And that's what it feels like sometimes. It feels really hard right now in healthcare. We're trying to do everything we can to support healthcare workers, making sure that they take time off, support each other, have the PPE that they need, and be at that space and place, and remind them this is not going to last forever. But we are seeing that, and that is, it's, you know, not trying to be driving up fear, not trying to make it sound worse than it is, but it feels like you're living in two different worlds when you go work in the hospital and then you come out in different space. But Lisa, what else would you add?
I would echo everything that Dr. Zink just said. I have the same experience, and I'm seeing physicians and nurses and healthcare professionals walking away from medicine, deciding that they're just exhausted. And that's really hard to see because that's a commodity in Alaska that we don't have spare healthcare workers. So I think as much as we can do as a community to support our healthcare systems and healthcare workers, it's very much needed at this time.
You know, I'll add it out there because I worked in the hospitals for a long time and have a lot of friends that still do. I think the number 1 thing we can do right now to support our healthcare workers is get vaccinated if you're not. You know, it's been a tough year and a half, and that's what I'll add to that.
Yeah, that's the number 1 thing you can do to support your healthcare workers in your community, your public health workers in your community, your police department, your fire people, everybody, your whole community. The most important thing you can do is get vaccinated.
Thank you so much, Hub Team, for sharing your experiences and those of your colleagues. All right, so quite a few questions here about when to quarantine, when to isolate. And I just wanted to point out to folks that Sarah from our Hub Team was kind enough to share some information about those parameters in the chat. So feel free to refer to those. Dr. Zink, would you like to do a quick little lightning round to address some of these additional questions?
Sure, we're at 8 minutes. I'm going to try to go through some of these quickly. I know this can be frantic and want to just try to get as many questions answered. Hub Team, if you see questions in the chat box that you can also answer by typing in, we'll do that as well. But there are some similar themes, and I'm just going to go through them quickly. There was a conversation about antibody titers. That's a check to see what your antibody levels look like, but that is not a perfect correlate to protection, and we're happy to talk about that more next week. Should vaccinated people stay away from events such as the state fair or food fires? Again, thinking about your underlying health conditions and considering additional mitigation strategies like testing prior to coming in, as well as wearing a mask if you choose to do so. When is it going to become like this flu in terms of prevalence? Jamie's entering, we continue to look for the flu, but we, from a state perspective, this is like flu on steroids. We are, messaging, we are encouraging vaccination. We are doing the same work that we've done in the past for flu. It's just we have a lot of it, and it's really overwhelming our healthcare system overall. And Jamie's got some additional information she'll be sharing. What's the significance of the plan for Pfizer Moderna before they applied for the EUA, and have they applied for the EUA? Pfizer has submitted for a full approval, and we're hoping to see that here in the next month. Moderna is putting that together in piece, and we'll continue to watch that. Why does the proportion of MATSU have low vaccination rate? Again, we're just helping to vaccinate at the speed of trust, and people have a lot of good questions and want to make sure that those are addressed. I think there's a lot of misinformation out there. More information about back to work for essential workers, please take a look at the CDC recommendations on that. There's been a 5.9% increase in vaccine compared to other weeks. That's comparing it to the past 2 weeks. It's hard to compare this to other states because everyone's measuring that a little bit differently, but continue to look at other states to see what they've done to increase vaccine rate. Do we have any data about new cases amongst vaccinated people? We are working on some additional information on that, but remember, we do have a monthly bulletin that includes hospitalizations and vaccine breakthrough. And as Joe mentioned, there's been some good summaries from national data on that. How can we combat misinformation and take politics out of it? And I think that's treating each other with space and grace and realizing we all want the best for our communities and continuing to work in that space. We are doing a lot of work from this end to continue to message outside of people who show up to this, and in other ways, this is just one of the mainly tools. There's some conversations about breakthrough infections and who may be eligible and should we be doing antibody testing. And again, I think we should probably include this for our slides for next week so we can talk about correlates because there's a lot of questions on that. It's a little bit more extensive. If beds are strained, where else can they go? Does Washington have beds? No, Washington really does not have many beds. And this affects both adult and pediatric care, and that's been the conversation nationally. So we continue to look for any way that we can provide additional resources out there. We don't have a lot more data on the J&J than the other two, and we kind of had mentioned that previously. Joe had kind of talked about that. As mentioned, we're trying to reach out to other people. There's a question on that. We talked about the new column we didn't actually talk about this, a new column for third dose vaccine. I know Kelsey and team are looking at how to display that on the dashboard and how other states are doing that, but we don't have a good answer for you there on that one. Is there any place in the United States that's reached herd immunity due to high vaccine rate? I think unfortunately with the Delta variant, we're seeing higher rates of reinfection. So people who previously had infected are 2.5 more times likely to get it, even if they were not vaccinated. And we are seeing vaccine breakthrough cases. So I think that the concept of herd immunity is becoming further and further from us. And this is really a lot about mitigation to minimize the overall impact on hospitalizations, deaths, and people getting sick. Lots of other conversations about yearly data on vaccine efficacy. Joe shared a lot of that information. I encourage people to take a look at those MMWRs, which he posted in the chat box. Why did India drop quickly? I think there's multi-factors that go into all of this, but in general, we do see places that go up really high and they go down. The problem is it's hard to know exactly when that point will be. We continue to look at other states and other countries, and maybe we can provide some additional information next week on that overall. Continue to provide information about vaccine breakthrough cases. There's more questions about that. There's questions about the VAERS data and how people got misinformation. There's just a lot of misinformation out there. Maybe we can do some more on the VAERS data in comparison to outbreaks and the concerns overall. And then there's a real positive information on who's doing what type of test and what qualifies a test or not. There's an information gap here, and we'll continue to work on that messaging. And there's some comments about, what do I tell my kids to get vaccinated and to get tested and to mask up, and again, share that information with them. In general, we want to make sure Alaskans are healthy and well and safe. So anyway, sorry that is fast. That's the ER version of me in here, but I also hate questions sitting in the chat box, but gives us some great tips and thoughts for next week's. So team, we've got 3 minutes left. What else have I missed? Anything else that you want to make sure that the public knows? That's a lot of silence after a lot of talking.
Okay, I'll jump in. So I think just to kind of circle back to the additional doses for immune compromised and booster shots, because I think it is confusing and there's been a lot of stuff in the media. So think of them as two different things. So we have now a third or additional dose, which is authorized for moderately to severely immunocompromised individuals. That's because those individuals didn't mount a good response, or some of those individuals didn't after the first 2 doses in their series. So they're now qualified to get a third dose for their initial series to hopefully get up to a more effective level. And so that is available now. That has been approved by the CDC, and the state is authorized this. So please, everyone, if you are unsure, if you're immune compromised, speak with your health provider, because we really want to get you covered. Second thing is, in all the media, and the White House had the press briefing today, booster shots looking down the pipe in September 20th as a date that we're looking towards. Those details are being worked out right now. We're looking at everyone 18 and older at this point, and it would be 8 months after your second dose in your primary series. And that's to boost your immunity. So that's a booster. We're worried about some waning immunity. We're worried about the Delta and how transmissible that is. And so this is an extra booster. So the initial people that will be 8 months out are the first people that got it. So nursing home residents, older than 65, some healthcare workers. And so looking forward, there's lots of details that need to be worked out with that. The ACIP is going to review that data. The CDC will then make an authorization. So we will keep everyone updated, but that's kind of the difference between those two. And there's been a lot of questions and confusion. So just hoping that helps a little bit.
And sorry, I know we're at time, but one other question that has come up is differential impact or vaccine effectiveness of Pfizer versus Moderna. And Lisa mentioned this Mayo Clinic study that has not yet gone through peer review. And that showed a big difference between the two, but some of the other studies that have come out have not shown a difference between the two, including at least one of the MMWRs that was published today. So just please hold on as we learn more information about that.
And as we wrap up, go outside, go take care of your mental and physical health. Don't let this overwhelm you. Fear is never a place of response. We will get through this together. There is a lot of hope out there. I know we have a lot of information at people and with people, but please make sure that we're kind and working with each other as we all get through this next phase of this pandemic together. Thanks.
Thanks so much, Hub Team, and thank you so much, Dr. Zink, for those closing words. I couldn't agree more. And leading off of that, I want to express a sincere thanks to all of our participants here today and all of the wonderful questions that you continue to share with us. We really appreciate them, and your participation makes this series so vital and thrilling. Thank you so much. All right, so our next session in this series will be next Wednesday, August 25th from 12 to 1 p.m. Please remember to visit the shared box folder to access videos and resources from all echoes, including those from today. Thank you so much, and we'll see you next week. Take care, everyone.
Thanks, everyone.